Welcome to this special clinical series, From Vascular Curiosity to Neurodegenerative Disease, a consensus statement for the diagnosis and management of MACTEL Type 2. For decades, macular telangiectasia type 2 was viewed as a vascular curiosity characterized by its subtle vascular abnormalities, including telangiectasia vessels and late-stage leakage. Emerging research and clinical consensus, however, have shifted the paradigm of MACTEL type 2 from a primary vasculopathy to a complex neurodegenerative disease centered on the dysfunction of miliar glial cells, which support both the functional and structural integrity of the retina and the subsequent loss of photoreceptors. As the understanding of the metabolic and genetic components of MACTEL type 2 evolves, clinicians are recognizing that standard metrics of visual function, specifically Snellen visual acuity, are insufficient for capturing the true burden of the disease. More appropriate measures include difficulty reading, metamorphopsia, and paracentral scotomas. In this 4-part video compendium, an expert consensus group of renowned retina specialists help us move beyond the traditional eye chart to explore the metabolic underpinnings, multimodal diagnostic protocols, and emerging neuroprotective therapies that are transforming the standard of care. Join us as we explore these perspectives to ensure that no patient is left behind in the Snellen trap. And for more details, we encourage you to use the QR code on this screen to read the full written consensus statement. As the understanding of the metabolic and genetic components of MACTEL type 2 evolves, clinicians are recognizing that standard metrics of visual function, specifically Snellen visual acuity, are insufficient for capturing the true burden of the disease. By the time a patient loses lines on the chart, the neurodegenerative damage is often irreversible. MACTEL type 2 affects central vision. As the disease progresses, patients may begin to report profound functional deficits, including difficulty reading, metamorphopsia, and paracentral scotomas, even while maintaining good visual acuity. Scotomas force patients to compensate with small eye movements, resulting in delayed reactions and other impairments not reflected in visual acuity. Studies show 47% of patients with MACTEL type 2 have absolute scotomas, and 94% of scotomas expand within 5 years. Because vision loss and visual function are irreversible, it is imperative that these patients are identified earlier in the disease state for effective management and monitoring. Consequently, a multimodal diagnostic approach is essential to identify structural changes, such as ellipsoid zone loss and retinal cavitations, before irreversible vision loss from MACTEL type 2 occurs. The MACTEL type 2 expert consensus group unanimously identified OCT as the essential baseline for confirming the disease. OCT can aid in making a MACTEL type 2 diagnosis, as well as help monitor for neovascularization. Common findings on OCT include disruption or loss of the ellipsoid zone, hyporeflective cavities in the inner and outer neurosensory retina, and internal limiting membrane drape.
A traditional OCT is, the gold standard. We get it on every patient anyway.
I usually do OCT to start with, and that will give me a hint. Sometimes it just gives me the diagnosis. There are many findings on OCT, such as the ellipsoid zone loss. In the absence of a history of, say, macular hole repair or other macular disease, If you have ellipsoid zone loss, you have ILM draping, you have characteristic cysts, you have, ways that the pigment is dropping out. Again, often we can make the diagnosis on OCT.
So there's lots of different things that we may see on a detailed exam. It's a lot easier when you get an OCT scan. So we see the cavitary lesions, which are the classic finding in this case, the draping. Sometimes the internal limiting membrane drapes over a cavitary lesion. The retina itself is not tremendously thickened like it is in cases of diabetic macular edema or macular edema related to vein occlusion. So there are cavities within the normal retina, and as the retina is not thickened with cavitary changes, it's the normal thickness. But we also see ellipsoid zone loss. That's the classic finding.
For the MACTEL Type 2 Expert Consensus Group, other important modalities include fluorescein angiography, fundus autofluorescence, and OCTA. As a diagnostic tool, FA produces essential images of the telangiectatic vessels, as well as leakage from the vessels. On the other hand, FAF is useful to detect the earliest stages of MACTEL. Macular pigment loss in eyes with MACTEL Type 2 is associated with increased autofluorescence.
I'll never label the patient with that diagnosis based on OCT alone. I typically get the fundus autofluorescence as well, which can show characteristic changes, and fluorescein angiography, which can show leakage in the macula in a characteristic fashion.
OCT, I do obtain fundus autofluorescence, and it's usually loss of hypoautofluorescence that we see in the fovea. Is typical, so we see hypofluorescent spot in the fovea, and then with this kind of changes that we see now extension of kind of hypoautofluorescence just temporal to the fovea. It's often related to pigment clumping there and deposits. Fluorescein angiography is very helpful because we also can kind of identify right angle vessels, telangiectasia portion of this disease. And that's quite visible on FA. There's temporal, in late stages, there's temporal kind of leakage in the foveal area. And sometimes, as I mentioned, patients have neovascularization as well, and that FA can really help us identify that and treat that with anti-VEGF therapy.
OCTA shows retinal and choroidal vasculature in high resolution without the need for intravenous dye.
In this disease, I have found it most helpful when you're not clear if a CNV has developed. And on an FA, there's always kind of this leakage that's present with or without a CNV. So sometimes the FA doesn't help. And so I find OCTA can be helpful if you're trying to determine whether a CNV is present.
OCTA right now has always been an adjunct to many of the other things that we do. This disease has been so well described with fluorescein angiography, autofluorescence, and OCT that OCTA is useful to assess, I think, the extent of, capillary loss.
Although it's not as widely available, I find that OCT angiography is super helpful because it really can show us those telangiectatic vessels temporal to the fovea.
The expert consensus group unanimously agree inner and outer retinal cavitation with preserved foveal contour, as well as cavitations with ILM draping, are two prominent OCT features that help them consider MACTEL in the differential. Other OCT features include ellipsoid zone attenuation and ellipsoid zone loss.
Sometimes there's vascular changes. Obviously, if you do a fluorescein angiogram, you typically show some vascular changes, especially temporal to the fovea. You'll get some telangiectatic vessels. You'll get some irregularly shaped vessels. You'll get some leakage in the late frames of the angiogram. So you will notice some vascular changes. You could also notice some pigmentary changes or crystals, like I mentioned. I mean, those are things that we see on exam. Sometimes late in the game, they have a lot of pigment changes. Sometimes they get choroidal neovascularization, where they get, I guess I should call it subretinal neovascularization, would be a more proper term, where they get exudation, which is lipid. They get fluid under their retina, and that's a very bad complication if it happens, but that's not that common.
When we're evaluating an elder patient who has some central vision complaints, OCT imaging of the central macular region is very helpful, both for diagnosis of MACTEL type 2 and also to rule out other conditions. So for instance, MACTEL type 2, we see these hyporeflective spaces, these black spaces within the retina that represent atrophy. And these hyporeflective spaces can also be termed as cavitations, these cavities where we're missing the retina. If we want to rule out another condition, age-related macular degeneration, we see a different sign. We see drusen, these hyperreflective subretinal deposits. If you see that on OCT, you might lean towards the diagnosis of age-related macular degeneration. So the different imaging signs we see on OCT can help the ophthalmologist and retina specialists go down a different pathway to make the correct diagnosis.
Some of the classic things that we see are these cystic changes that occur in the retina using the internuclear outer plexiform layer. You can see a flattening of the fovea, thinning of the fovea. We can get this draping of the internal limiting membrane over the retina. And sometimes that's mistaken for an epiretinal membrane. And I've seen some of those patients have surgery for that, and it doesn't help in that case. And then, of course, the outer retinal band changes that we see, particularly in the ellipsoid zone, where we're losing the ellipsoid zone and we're losing the photoreceptors in those areas, and it can extend. We can also see reflective foci in the retina, the pigment as the pigment migrates into the retina. And on OCT angiography, of course, we can see telangiectatic changes, right angle venules, changes in mostly in the outer or the deeper plexiform vascular layer, but also in the more superficial layer in some patients as well. And neovascularization can be seen too, or suspected, and really confirmed with OCT or fluorescein angiography in those cases.
Well, for sure, just a structural OCT. There's lots of features that are really characteristic of MACTEL, including those hollowed out cavities, which can kind of quote unquote look like CME, cystoid edema, but it's not really edema, it's actually loss of tissue. The ILM drape, the EZ break, RPE migration into the retina. Those are all kind of characteristic signs. I like to, and I still will get an FA at baseline to confirm the diagnosis. I don't routinely get an OCT angiogram. Sometimes I'll get a fundus autofluorescence, but to me, honestly, the OCT is the key.
In the old days, it was clinical exam and fluorescein angiography, because we'd look at these characteristic vascular changes in the macula and use that as a diagnostic criteria. And certainly those are important in many cases, particularly when there's some diagnostic dilemma. Oftentimes I see patients that are referred for what the primary eye care provider thinks is diabetic eye disease. And so it's important oftentimes to do angiography to differentiate the vascular changes in diabetic macular edema from MACTEL. But really in today's world, the most important diagnostic imaging is OCT, because you can really more clearly delineate the disruption in the photoreceptors, which is really what's the problem here. The problem here is not really the vascular changes. That's a late finding. The problem is degeneration of the retina, and we can see that by evaluating the ellipsoid zone on OCT.
Thank you for joining us for this video compendium on MACTEL Type 2. As we journey from the microscopic failure of serine metabolism to the macroscopic challenges of differential diagnosis and the surgical frontiers of neuroprotection, the goal is clear. Increase awareness, utilize multimodal imaging, and intervene within the therapeutic window to preserve visual function. A diagnosis of MACTEL Type 2 should not be a surprise in late-stage atrophy. it should be a proactive discovery. By combining OCT, FA, FAF, and microperimetry, we can give a name to a patient's struggle and prepare them for the therapeutic options on the horizon. In the next video, we explore the therapeutic frontier in MACTEL Type 2. For more details, we encourage you to use the QR code on this screen to read the full written consensus statement. Together, we can move from passive observation to active preservation.